I want you to try something for me right now,
Yeah.
wherever you are, unless you're driving, obviously. But just, take a second and swallow.
Okay. Done.
Now, really think about what just happened.
Hmm.
You didn't have to, calculate the trajectory of your saliva.
Yeah.
You didn't manually shut your windpipe or tell your tongue to push backward at a specific angle.
No, it's completely automatic. It's one of those background processes, like your heart beating or your eyes blinking, that you barely notice.
Until it stops working.
Exactly. It's a hugely coordinated neuromuscular event.
And we take it for granted hundreds of times a day. But imagine if that mechanism, broke.
Mm-hmm.
Imagine you take a bite of a sandwich, and instead of sliding down, it stops.
Ugh.
Not because you're choking in the traditional sense, but because there's a literal wall inside your throat blocking the way.
That is a terrifying thought. That sensation of obstruction is incredibly primal. And what makes the condition we're looking at today so fascinating is that the cause of that wall isn't a tumor or a bone you swallowed. The clue to the blockage is actually written on your fingernails.
That is the hook for today's deep dive.
Yeah.
We are unpacking a medical mystery based on a fantastic lecture and case study from Dr. G.S. Raju's YouTube channel. Specifically, we're looking at a video titled Pathology of Esophagus Esophageal Web.
And Dr. Raju gives us a real masterclass here in clinical observation. We aren't just looking at a sore throat. We're looking at how the body is this deeply interconnected system.
Right.
Where a nutritional deficit in your blood can physically restructure your anatomy.
It is pure detective work. We are going to follow the case of a woman in her 50s who couldn't eat solid food. And by the end of this, you're going to understand what an esophageal web is, why spoon-shaped nails are a major red flag, and how doctors physically break through that barrier.
It's a remarkable condition. Let's start with the basics of the breakdown because difficulty swallowing is, well, it's a pretty broad term.
Let's do it. The medical term is dysphagia.
Yeah.
But Dr. Raju makes a point to split this into two very distinct categories right off the bat. It's not just one thing.
Right. Dysphagia isn't a one-size-fits-all diagnosis. When a patient says, I can't swallow, a doctor's first question has to be where?
Where is the traffic jam?
Exactly. Is it at the on-ramp or is it, on the highway itself?
That's a great analogy. So Let's talk about the on-ramp problem first. That's oropharyngeal dysphagia.
Correct. Oro for the mouth, pharyngeal for the throat. This is a problem initiating the swallow. The handoff from the mouth to the esophagus fails. And this is the really dangerous one in the immediate sense because of the anatomy involved.
Because if it doesn't go down the food pipe, it has to go somewhere else.
Yeah.
And looking at the diagram, the neighbors are, well, the lungs and the nose.
Exactly. And there are only two other options, neither of them good. It can go into the trachea, the windpipe, which causes aspiration.
Food in the lungs.
Food in the lungs, yeah, leading to pneumonia or just choking. Or it can go up.
Measles regurgitation.
Which is exactly what it sounds like. Food coming back out the nose. It's distressing and messy. But that is not what our patient today has.
Right, she has the second type, esophageal dysphagia.
This is the highway problem. The transfer works fine. The food leaves the mouth. It skips the windpipe. Everything is working perfectly up top. But then, as it travels down that tube towards the stomach, it hits a roadblock.
And Dr. Raju identifies the specific roadblock in this case as an esophageal web, specifically a postcricoid web. Now, explain postcricoid for us without making us pull out a medical dictionary.
It sounds almost extraterrestrial, doesn't it? Postcricoid web. But anatomically, it's quite specific. The cricoid is a ring of cartilage in your larynx, your voice box. So postcricoid just means this web is located just behind that area, the very top of the esophagus.
So we're talking high up in the chest, basically right at the entrance of the esophagus.
Precisely. It's right below the upper esophageal sphincter. It's the gateway to the stomach, essentially.
So to really understand this, we need to look at the patient Dr. Raju presents. We have a woman in her 50s. What brings her in?
Her primary complaint is classic for this condition. She has difficulty swallowing solids, and she's been struggling with it for a few months.
And that distinction between solids and liquids is really important here, isn't it? She could still drink water.
Oh, it's critical. If you have a total blockage, nothing goes down. But a web is usually a partial obstruction. It's kind of like a shelf.
Okay.
So liquids can wash over it or trickle past, but a piece of steak or bread, that's going to get hung up.
So she can drink her coffee, but she can't eat dinner. Now, if I'm the doctor, I'm thinking, okay, something is blocking the pipe. But Dr. Raju points out this whole cluster of other symptoms that seem completely unrelated to her throat.
This is where the deep dive really begins, because if you just treat the throat, you miss the disease. He notes she's complaining of generalized weakness and fatigue.
Which, let's be honest, could be anything. Stress, lack of sleep, the flu.
Totally. But she also reports dyspnea, shortness of breath, and heart palpitations.
Okay, so her heart is racing, she's out of breath, and she's exhausted. That sounds like her body is starving for energy.
Or oxygen. Palpitations and shortness of breath are the body's way of compensating when the blood isn't delivering enough oxygen. So the heart beats faster to try to cycle the blood more quickly.
So we've got a systemic issue. But the physical exam reveals even stranger clues, and this is the part that really stuck with me. The fingernails.
Yes, this is a classic board exam question for med students. The patient has koilonychia.
Koilonychia, that's the medical term for spoon-shaped nails.
Correct. Instead of the nail curving outward like a convex lens, it actually dips inward. It becomes concave. You could literally hold a drop of water in the center of the nail like a spoon.
That is such a specific, bizarre change. And it wasn't just her nails, right? Her mouth was showing signs, too.
Yes. Dr. Raju notes glossitis, which is inflammation of the tongue. It gets red, smooth, and sore because the papillae, those little bumps on your tongue, actually atrophy. They disappear.
Wow.
And she also had angular stomatitis.
Which is the cracking at the corners of the lips.
Right. Where the upper and lower lips meet, the skin gets irritated and cracked and painful. It's often mistaken for just, dry skin, but it's much more persistent.
So let's pull this all together. We have a woman who can't swallow solids. She has spoon-shaped nails, a red tongue, cracked lips, and she's exhausted with a racing heart. To a layperson, this looks like 5 different problems.
But in pathology, you're always looking for the unifying theory. Occam's razor, is there one thing that causes all of this? And in this case, there is.
It's a syndrome.
It is. This whole constellation of symptoms is known as Plummer-Vinson syndrome, or, depending on where you are in the world, sometimes Patterson-Brown-Kelly syndrome.
What's the smoking gun? What connects the spoon nails to the throat web?
Iron deficiency anemia.
Anemia.
Yeah.
It seems so basic. We hear about anemia all the time. Eat more spinach. But I didn't realize it could cause structural changes like this. I thought it just made you tired.
And that's the insight here. We tend to think of iron just as fuel for hemoglobin, which it is. If you lack iron, you can't make hemoglobin. You can't carry oxygen, and you get the fatigue and the heart palpitations. So that explains the systemic symptoms.
But the nails in the web, how does low iron warp a fingernail?
Well, iron is also essential for enzyme function in rapidly dividing cells. The cells in your fingernails and the lining of your mouth and your throat, they turn over very, very quickly. They need constant maintenance.
Okay.
When you have severe chronic iron deficiency, those tissues start to degrade.
So the spoon nails are actually a result of the nail bed failing to form correctly because it's starved for iron.
Exactly. The matrix of the nail becomes thin and weak. And the glossitis and angular stomatitis are the same mechanism. It's called mucosal atrophy. The tissue is thinning out and getting inflamed because it can't maintain itself.
And the web in the throat, is that atrophy too?
That is the most extreme manifestation. The theory is that the iron deficiency causes the cells in the esophageal lining to become, brittle and abnormal. As the cells turn over, they fail to separate correctly, and they eventually fuse or grow into this thin, fibrous membrane that just spans across the lumen.
It's incredible. The body is literally building a barricade because it doesn't have the materials to build a proper wall.
That is a great way to put it. It is a structural failure driven entirely by a nutritional deficit.
So you can't diagnose the web just by looking at the nails, but the nails tell you, hey, you should probably look for the web.
Exactly. Dr. Raju really emphasizes this association. If you see the web, you check the iron. If you see the spoon nails and the dysphagia, you look for the web.
Let's talk about finding that web. Dr. Raju mentions a very specific behavioral clue the patient gives.
Yes, this is clinical gold. When you ask a patient with this condition, where does it get stuck? They don't just wave their hand vaguely over their chest.
What do you point?
They point specifically to the neck, usually right at the level of the cricoid cartilage. Because the obstruction is so high up, the sensation is very localized. They can feel exactly where the bottleneck is.
So the doctor goes in with an endoscope to confirm. Paint the picture for us. What are we seeing on that screen?
So the endoscope passes the upper esophageal sphincter. You're looking down the tunnel of the esophagus. Normally, it should be a smooth, open tube, a clear lumen.
Like looking down a garden hose.
Right. But in this case, you see a shelf, a thin, sort of semi-transparent membrane of tissue just cutting across that opening.
Right.
It's usually on the anterior side, the front side, but it can be concentric, meaning it circles the whole pipe.
And Dr. Raju describes it as catching the food.
Yes, you can just visualize. A bolus of chewed food comes down, it hits this shelf, and it just piles up. That is the dysphagia.
So you've found it. You know it's Plummer-Vinson syndrome. You know it's iron deficiency. How do you get that web out of there? Do you have to cut it out surgically?
Not usually, no. The treatment Dr. Raju outlines is mechanical, but it's less about cutting and more about force. The term is dilation.
Stretching.
Aggressive stretching. Dr. Raju actually uses the word rupture.
That sounds violent. Rupturing the web?
It sounds intense, but it's the most effective method. Because the web is so thin and membranous, if you force a large enough object through the esophagus, the web will just snap or tear. It clears the path. It's like breaking a seal.
And he lists specific tools for this. It's not just shoving the camera through.
No, the camera usually isn't wide enough to do the job effectively. You need specific dilators. He mentions 2 types. First, the savory dilator or a bougie.
A bougie.
It's a long, flexible, tapered tube. You slide it down the throat over a guide wire. As the tapered part goes through, it gets wider and wider, and it exerts this radial force on the web until pop, it breaks.
And the second tool?
A balloon dilator. And this is exactly what it sounds like. You pass a deflated balloon into the stricture, and then you inflate it to a specific pressure. As it expands, it breaks the web.
But here's the key detail Dr. Raju emphasizes. Size matters.
Oh, it's a critical point.
Yeah.
He specifies you need a dilator that is 18 to 20 millimeters in diameter.
That's roughly 3/4 of an inch. Why that specific size?
Because that's roughly the normal diameter of a healthy human esophagus. If you use a 12 millimeter or a 14 millimeter balloon, you might stretch the web a little, maybe give them some temporary relief, but you won't fully rupture it.
No.
You'll leave parts of the shelf behind, and the symptoms will just come back. You have to restore the full patency of the lumen.
So you have to be bold. You have to go for the full 20 millimeter.
You do. The goal is to completely clear the obstruction so the patient can eat a steak dinner that night.
So procedure done, web ruptured, the patient can swallow. Are we finished?
If you stop there, you are completely missing the forest for the trees.
Because of the anemia?
Precisely.
Mm.
Breaking the web fixes the symptom, but it doesn't fix the patient. Dr. Rajan is very clear about this. It is important to treat her anemia.
You have to restock the iron shells.
You have to get those iron levels up to resolve the fatigue, the heart issues, the nail changes. But Dr. Raju goes even deeper. He says you have to figure out why she has iron deficiency in the first place.
Right. You don't just get iron deficiency for no reason. It's not normal for an adult.
Exactly. Is she losing blood from an ulcer? Does she have a heavy menstrual cycle? Does she have something like celiac disease preventing absorption? Or is it just a really poor diet?
If you don't find the leak, you're just filling a bucket with a hole in it.
And the web could come back. Plummer-Vinson syndrome is a chronic condition if that underlying nutritional deficit isn't managed.
There's also a darker reason to keep an eye on this, isn't there? I remember the source material mentioning a risk associated with these webs that goes beyond just choking.
Yes, and this is a crucial insight. Plummer-Vinson syndrome is considered a pre-malignant condition.
Pre-malignant. So, cancer risk.
There's an increased risk of developing squamous cell carcinoma of the esophagus or the pharynx in these patients. It's not a guarantee, obviously, but it elevates the risk significantly compared to the general population.
Which makes treating the anemia and surveillance even more important. It's not just about swallowing comfort, it's about long-term cancer prevention.
Exactly. It circles right back to Dr. Raju's holistic approach. You aren't just a mechanic fixing a pipe, you are managing a systemic disease with long-term implications.
It's just a fantastic example of how one small complaint, I can't eat solid food, unravels a whole tapestry of pathology.
It really validates the importance of the physical exam. You know, in an era of high-tech scans and MRIs, sometimes the answer is just looking at the patient's hands and mouth. You can't see spoon-shaped nails on an MRI.
Dr. Raju ends the video by giving credit to his team, which I think is a really classy move. It shows how collaborative this work is.
Yes, he mentions Dr. Storline, Mr. Charles Butt of HEB, and the medical illustrator Ms. Angela Deal.
Those illustrations by Angela Deal are just vital. It's one thing to hear esophageal web, but seeing that drawing of the membrane really helps you understand what you're up against.
Visualizing pathology is half the battle in understanding it. It bridges that gap between the abstract concept and the physical reality.
So let's wrap this up with a quick recap for our listener.
Sure. We started with esophageal dysphagia, difficulty swallowing solids because of a blockage.
We looked at the physical clues: spoon-shaped nails, koilonychia, an inflamed tongue, glossitis, and fatigue.
We connected those dots to iron deficiency anemia, which led us to the diagnosis of Plummer-Vinson syndrome.
The culprit was the postcricoid web, a thin membrane in the upper throat.
And the solution was twofold: mechanical dilation with a large 18 to 20 millimeter tool to rupture the web, and then systemic treatment of the anemia.
Simple, elegant, and, well, life-changing for the patient.
Absolutely.
You know, this whole deep dive leaves me with a lingering thought. We talked about how a lack of iron, a simple element on the periodic table, can force the body to literally build a web in the throat.
It's a powerful example of structure following nutrition.
And it makes you wonder, what else is happening inside us right now? We usually think of you are what you eat as a metaphor for, weight or energy. But this proves it is literal architecture.
It is. The body is always remodeling itself.
If a lack of iron builds webs, what structure is being rewritten because you're low on magnesium or vitamin D? What other blueprints are being silently altered in our deep anatomy just because we skipped a food group for a few years?
That is a provocative thought. We view our anatomy as fixed, bones and organs that are just there. But the reality is that our anatomy is plastic. It's constantly being maintained and rebuilt by our biochemistry. When the supply chain breaks, the construction changes.
We might be walking around with all sorts of webs we don't even know about yet.
Until a symptom appears.
Something to chew on. Carefully, of course.
Indeed.
Thanks for joining us on this deep dive into Dr. Raju's fascinating case study. We will see you on the next one.
Goodbye.